Hello, welcome to this presentation on the new v-gel advanced airway devices for rabbits. My name is Ivan Crotaz. I'm a veterinary surgeon from the UK and I work also with Doc Innovent on the design and development of these v-gel airway devices. We're going to talk about the history and background of v-gel. Where did it come from? We're going to talk a little bit about intubation, pros and cons, when I would use it, when I wouldn't use it, what's new with the v-gel advanced, and then we're going to finish with how I fit the v-gel advanced within my rabbit anaesthetic protocols. V-gel airway devices then, what are they? Well, they're veterinary supraglottic airway devices. And supraglottic airway devices are devices that manage the airway from a position dorsal to the larynx. If you want to ventilate a patient, you've basically got three choices. You can put a face mask over the mouth and nose to form an airway seal at the front at the top. All well and good, except that if anything blocks nasal secretions or anything like that, you've got a blocked airway. When you ventilate, you can force gases down the esophagus and into the stomach, and of course face masks leak. So if you're using volatile anaesthetic agents, you're talking about a lot of environmental contamination and a health and safety risk to your staff. Supraglottic airway devices sit over or around the larynx, so they're forming an airway seal essentially within the pharynx itself, and they're not going down into the trachea like an endotracheal tube would. And then of course endotracheal tubes are placed through the larynx and right down into the trachea to form an airway seal much deeper. You may have heard of supraglottic airway devices being called laryngeal masks. The laryngeal mask airway, or LMA, is one make of supraglottic airway device designed for humans and used in human anaesthesia. The reason you'd use a supraglottic airway device is to reduce the upper airway trauma associated with an endotracheal tube. Because you're passing that tube all the way through the larynx, you can do a fair bit of damage on the way down. But in order for a supraglottic airway device to work, it's got to be the right shape. And of course, each species has a slightly different shape of larynx, epiglottis, pharynx. So you have to match your device with the species that you're working on. Where did the v-gel come from? Well, v-gel was designed by Dr. Nasir, the inventor of the human eye gel. And here you can see a human eye gel in a cross-section view curving round the base of the tongue. And you can see that large, soft green cushion material matching up to the laryngeal anatomy to give you an airway seal. Cat and rabbit v-gels were launched in 2012. And here you can see the cat and the rabbit v-gel devices. You'll notice that they have broadly similar shapes, but they differ in the details, and that's to allow them to match the anatomy of each species. And then behind the scenes, we have continuous research work progressing, and that's resulted in v-gel advanced for cats and rabbits, and other work going on in supraglottic airway device design for other species. Potential complications from endotracheal tube use then. Endotracheal tubes have a place in rabbit anaesthesia. There are times when they are necessary devices, but you should always consider what the complications might be. For me, one of the biggest ones is the trauma to the tracheal epithelium. Now, this is what tracheal epithelium looks like. It's a ciliated mucosal epithelium. The cilia are little hairs which beat debris and bacteria trapped in a layer of mucus from the depths of the lungs up to the top, and that's called the mucociliary escalator. And that's a very important part of the immune system of the lower respiratory tract in all mammals. When you intubate, as you can see, anywhere where you touch on that ciliated epithelium, you are amputating those cilia from the surface of the epithelial layer, and as you can see, it takes quite some time for them to grow back. And in that period, the mucociliary escalator is disrupted, and it's no longer going to be able to efficiently or potentially at all remove debris from the base of the lungs up and out of the respiratory system. And particularly in rabbits who have quite significant lower respiratory tract infection, often as a result of bad breeding or bad husbandry, that could be very significant indeed. And you may be getting animals with lower respiratory infection as a direct result of your anaesthesia. And that's not a question of how you intubate. That is inherent in passing something down the trachea, so you need to consider it as a complication every single time you intubate any mammal. Airway narrowing. Obviously, by definition, if you're passing a tube down the trachea, you are going to narrow the airway, and you're going to narrow it quite significantly, probably around about 50% reduction in diameter in most of our pet rabbit anaesthetics. So that's taking it from a 5.5mm or 5mm internal diameter trachea down to a 2.5mm to 3mm internal diameter endotracheal tube. And broadly speaking, that's going to make it about 16 times harder. There's an inverse to the fourth power relationship between diameter and resistance. So about 16 times harder for your patient to breathe. And as you'll see, rabbits don't breathe under anaesthetic at the best of times. So that's something that you need to consider. And I would suggest if you're intubating rabbits, you need to be thinking about assisting ventilation, either with IPPV, with a rebreathing bag squeeze, or with a ventilator. Unguided intubation or blind intubation is still a very common technique all the way around the world, and essentially for those of you who've not done it, you're passing the tube into the pharynx, you're listening for breath sounds, and then when you hear breath sounds, you're trying to pass the tube down the larynx. Even for those of us who are good at it, you are still prodding the end of quite a sharp pointed tube around the larynx, and the potential laryngeal traumas there are very significant. And again, it's not really a question of technique. If you are not looking at where the end of the tube is going, the risk of traumatizing the arytenoid cartilages in particular, but also the body of the larynx and the epiglottis are quite significant. And when you're intubating, however good you are at passing an endotracheal tube in a rabbit and whatever technique you're using, it still takes longer than passing a v-gel and placing a v-gel. So hypoxia, hypercapnia are quite significant complications of the longer induction period that happens when you're intubating your patient. And then you're getting a reduced quality of recovery because, particularly if you're using a blind technique, you're creating more upper airway trauma or potential upper airway trauma that can cause discomfort or pain in the recovery period. And like any mammal, the more pain they're in, the less well they're going to recover, the longer it's going to take for them to start to eat again. What we're seeing here is another potential complication. This one is relatively commonly seen in referral practice as a complication of endotracheal tube use. And obviously rabbits have got very sharp incisors. When they're recovering, if they recover quicker than you were expecting, they can bite down on their endotracheal tube, amputate it, and then inhale the tube. And let's just have a look. So what you're seeing here is an endoscopic procedure to retrieve that tube. The interesting thing to look at the mucosal trauma that's been caused on the dorsal aspect of the larynx by the intubation and subsequent re-inhalation of the tube. It's quite significant. So you'll just see in a moment there's some bleeding dorsally. And that's all quite inflamed, unhappy tissue there. There's the tube down in the depth of the trachea. And you'll see more hemorrhage. This tissue does not like to be touched. That's the tube retrieved. So if you are intubating rabbits, you need to be thinking about some kind of tube protection. For instance, passing the distal end of that tube through an appropriately sized syringe in order to protect it from accidental amputation. It doesn't happen often, but when it does happen, it's very, very serious indeed. Okay, so when would I still choose to use an endotracheal tube? Well, there are certain situations. v-gel and v-gel advanced devices work by filling the pharynx. They are forming a seal around the larynx. So if you need to access the pharynx, you're going to need to use an intubation technique, or alternatively, you're going to need to maintain your patient on intravenous agents. If you need very wide access to the mouth for complicated oral procedures, then although the v-gel advanced devices have got reduced bulk, you're still going to need, in certain situations, more access. You may choose to intubate at that point. And if you're doing complex thoracic procedures where you need to ventilate one lung but not the other, then obviously maintaining the airway from the level of the larynx is not going to work. You're going to have to pass something down a bronchus. What I would suggest is if you're in these situations, the early part of anaesthesia, the immediate induction and post-induction period, is much easier with v-gel. You can place a v-gel and get an airway in seconds and ventilate the patient and stabilize them. So in those situations, I would consider placing your v-gel device, ventilating your patient so you get the oxygenation under control, you get your CO2 to an appropriate level, nice stable plane of anaesthesia, and then once you've stabilized your patient, then place an endotracheal tube. My recommendation always with intubation is to use a guided technique, and there are several guided techniques out there. Endoscopic guidance is generally the best, and that's the one that's going to place least strain on the oral structures. v-gel Advanced then, what's new, what's different to the original v-gel? Mainly what we've done here, we've upgraded everything about them. So the pharyngeal section in particular has been upgraded from softer wide cushions which mould around the larynx to a thin-walled seal which is very flexible and that wraps around the larynx like a curtain. That change in the pharyngeal section gives us an easier insertion. It makes our v-gel more stable during use, so you're less likely to lose that seal and lose that airway during anaesthetic. And I find it very much easier to use either mechanical ventilation or IPPV. We've taken the bulk of the oral section down, so we've improved the access for dental procedures, and we've changed from a multi-use device to a single-use device. That's really there to eliminate the risk of cross-contamination. Rabbit viral hemorrhagic disease 2 virus is now very common in many areas around the world. And it is a significant risk of cross-infection in rabbits. So a single-use device makes sense from that point of view. We've changed the connector end to reduce the dead space down even further, but we've maintained that nice airway width all the way through the device. So we're maintaining the width roughly of the trachea of that animal, so we're not reducing the space down and increasing airway resistance. And here you can see an image of the v-gel Advanced. This is a size 2. You can see the thin-walled flexible seal there sitting over the larynx, and that's giving us better seal performance. We've still got the esophageal plug that we had in the original v-gel, and that's there to stop any reflux fluid or esophageal mucus coming out of the esophagus and into the airway. We've taken the oral section diameter down, but as I said, we're still maintaining that nice wide airway throughout the device. And we've got an improved connector that knocks dead space down even more. Little change with the securing points here to avoid the incisors, and that makes the v-gel easier to insert. And we've changed the ventral aspect of the device slightly to take even more pressure off the vessels at the base of the tongue, and that minimizes lingual venous congestion. Here you can see a lateral view, cross-sectional view, and you can see that thin-walled seal wrapping around the epiglottis and the body of the larynx. And again, that's there to give us that nice stable position and much higher seal pressures. Broadly speaking, when I'm ventilating rabbits, I will ventilate at between 11 centimeters of water and 17 or 18 centimeters of water, depending on the needs of the patient. And these v-gel Advanced devices will easily seal within those ranges. Why have we gone and done this then? Why have we made these upgrades to the rabbit v-gels? Well, rabbits have got a very small chest capacity, very small ventilative capacity, and that's further reduced by other factors specific to rabbits. Chronic respiratory disease, very common in pet rabbits. Lung compression from anatomical factors. If you see there how the diaphragm arches up and over the liver and the stomach, and there's quite a lot of lung space dorsal to the diaphragm. So when you turn that rabbit on its back for surgery, a large amount of that lung capacity is being compressed by abdominal contents. And then they have a nasty habit of breath holding, either as a result of stimulation or a light plane of anaesthesia, and when rabbits smell volatile anaesthetic agents and sometimes even fresh gas oxygen flow, they don't like it and now hold their breath. The v-gel Advanced has got this better airway seal, so ventilation is very, very important in rabbits, either IPPV, squeezing the rebreathing bag regularly, or using a ventilator. It's got that greater stability, so it's much less prone to displacement compared with the original v-gels, and that means that you can move the rabbits around more, and you should still check every time the v-gel has been moved or the rabbit's been moved to make sure that your airway is still present, but there's much less fiddling around with them than there was with the original v-gels. And then we've got that reduced dead space. Now, dead space is very important. Dead space is the amount of gas that you've got to move before you get to fresh gas flow. And if you start putting more complicated devices in there, so the device itself has a larger volume, that means that all of that volume of gas has to be moved before your rabbit's going to get pure oxygen. And what we've done is we've changed the internal dimensions of the v-gel, and we've maintained that nice wide airway, but we've taken out any extraneous bulk, and that gets the dead space down to the absolute bare minimum. Laryngeal spasm is surprisingly common in rabbits, and it's worth just discussing this for a moment. And common causes of laryngeal spasm, the absolute biggest one is intubation. And by using either original v-gel or v-gel Advanced, you eliminate that risk because you're not touching the trachea at all. You're not putting things through the larynx and all the way down there. So it's a much less traumatic technique. Anything that touches the pharynx or soft palate or laryngeal structures is going to activate a protective mechanism. So that's a transient spasm that closes the airway momentarily, and then as that stimulus goes away, the larynx will reopen. So it's a much less severe cause of spasm. And sympathetic stimulation during anaesthesia, or pain as you'd think about it, is also going to give you a transient spasm until the pain goes away. So those are our three basic causes, and of those three, the intubation related trauma is the most severe. So either original v-gel or v-gel Advanced will eliminate that risk. v-gel Advanced has a little bit more benefit over the original v-gel because we've changed the shape of the seal. We're touching even less of those structures in the pharynx. There's even less contact between the v-gel and the anatomical structures around it. So v-gel Advanced is even less traumatic than the original v-gel. What do we do about managing laryngeal spasm? Well, the most important thing, if you've got a v-gel in place, is to think about the non-intubation causes. And that's touching pharyngeal structures when the patient's not at an adequate plane of anaesthesia, and insufficiently controlled pain during anaesthesia. What do we then go and do about it? Well, it's much easier to manage than an intubation trauma spasm, and you want to look at what the cause is. And you've broadly got two causes commonly. If you're seeing or hearing a laryngeal spasm in the induction period, that's going to be because your patient is not at an adequate plane of anaesthesia. So you'd remove the v-gel, would normally place a face mask over the rabbit, ventilate the rabbit with some oxygen, deepen the plane of anaesthesia, and in my experience, the best way of doing that is to use an intravenous agent. And in the UK, the licensed intravenous agent for rabbits would be Alfaxan, and that's certainly what I use if I hit that problem. If you're seeing or hearing a laryngeal spasm during the maintenance phase of anaesthesia, you would identify the cause, which is generally sympathetic stimulation or pain. You deepen the plane of anaesthesia you would provide extra pain management, and you would deepen the plane of anaesthesia. And that very much depends on the cause and what other anaesthetic factors you're trying to deal with at that time. Lingual venous congestion is something that people occasionally saw with the original v-gels. Anything that you place in the pharynx that's anywhere near the base of the tongue can press down slightly on the tongue tissue, and it can slow the return of blood through the lingual veins back into the circulation. So you've got lingual congestion, a slight change in colour of the tongue and shape of the tongue. I've also seen that in intubated cases where an endotracheal tube is resting on the base of the tongue. So it's any structure near the base of the tongue. V-gel Advanced has had a slight shape change compared with the original V-gel, and it minimises that effect, but you can still see a slight colour change of the tongue occasionally, and sometimes a drying of the tongue surface. You manage that in the same ways you would have managed it with the original V-gels or with an endotracheal tube. And I have seen no adverse effects as a result of V-gel Advanced placement. So what you do to manage it, reposition and massage the tongue during the 5-minute formal anaesthetic checks that you're doing anyway, moisten the tongue if you see any drying, and if you feel it's significant, you can check your V-gel size and use a smaller size if that's appropriate, which is going to press down less on the lingual tissue. But I would stress that it's something you should observe and manage, but not panic about. My experience then, from endotracheal tubes to the original V-gels and then V-gel Advanced, what do I find with them? Well, original V-gels, those of you who've used them, they are massively faster to place than an endotracheal tube. You don't have the risk of blockage because you're dealing with that nice wide airway. We saw much better quality of recovery and repeated procedures, and particularly if you're doing things like repeated abscess drains or repeated dentals, are less traumatic than endotracheal tube because you're not trying to wait for the trachea to recover from each intubation. When I switched to V-gel Advanced, what I found was more stability. So you didn't have that loss of the airway sometimes when you reposition or turn the rabbit. I found it much easier to use a ventilator. I can place the V-gel, plug it into my ventilator, turn it on, and off I go. And lingual congestion is less common, and it requires less intervention, less massage and messing around when you do see it. Now, my rapid anaesthetic protocols, what do I do with V-gel Advanced to work them into my anaesthetic protocols? What I'd like to do is go through how I construct my anaesthetic protocols and how I work with anaesthesia in rabbits, and then how I drop V-gel Advanced into that. One of the most important things, if not the most important things to think about with anaesthesia, is the human factor. And this is a nice quote: there are no safe anaesthetic agents, no safe anaesthetic procedures, there are only safe anaesthetists. And it's very true. Human factors in anaesthesia are one of the most important things. Checklists are all well and good. Checklists are important and you should always do them. But a checklist with the wrong culture is useless. Checklists can be ignored, glossed over, laughed at, and they frequently are. So what you need to do with human factors is build a culture within your operating theatre where people are thinking about anaesthetic safety from the moment the patient comes in the building to the moment the patient leaves the building, and ideally, in fact, before the patient even enters the building in the first place, if you're working in general practice and you can influence the husbandry of those animals. So when we're looking at drug use with anaesthesia, there are 3 drug types that we can use. There are drugs that have a sedation or anaesthesia effect, like isoflurane, sevoflurane, alfaxanolone, propofol, those sort of drugs. There are drugs which we use as analgesic agents, so that might be buprenorphine, methadone, non-steroidal anti-inflammatories, local anaesthetics. And there are drugs which provide muscle relaxation. I put these in brackets. Very few of us in clinical practice with rabbits use muscle relaxants, and the reason for that is that you then have to take a lot more responsibility for ventilation. Muscle relaxants are very useful drugs, but you need to be working at a high level of anaesthesia in order to use them safely. So generally speaking, drugs which are good sedation or anaesthesia agents are not particularly good analgesic agents. Agents which are good analgesic agents are not necessarily good muscle relaxants. And what you're trying to do is build up an individual drug group for your patient that has components of sedation or anaesthesia, analgesia, and muscle relaxation. And I would keep those things in mind. And then, for instance, if you feel that you are doing a non-papal procedure, so you're giving a patient sedation in order to take a thoracic radiograph, you don't need to worry too much about analgesic agents that are just adding in potential adverse effects and you can concentrate on the sedation side of things. If you are going to be doing something along the lines of an abscess, lance and drain, and you want to be doing a balanced analgesia, you might want to be thinking about using local anaesthetic agents like lidocaine or bupivacaine, and maybe adding in some non-steroidal anti-inflammatory agents if you're expecting soft tissue pain. And then you might want to be thinking about an opiate as well, depending on how painful you're expecting that procedure to be. So generally speaking, try and stay away from recipes and say it's a rabbit, it gets this, and try and think about the procedure that you're doing, think about the behaviour of that animal, the husbandry of that animal, its state of health, its age, other concurrent diseases, and build a protocol for that patient that's individual to that patient. And that's going to enormously improve your safety. Starting then from the preoperative period, think about the husbandry. Is that animal sitting in a badly ventilated hutch with high dust levels, lots of mold, that sort of thing that's going to increase its risk of lower respiratory tract disease? Think about breed, think about general health. Breed's important. We are seeing some brachycephalic small breed rabbits coming through now. Brachycephalic rabbits are going to have less ability to ventilate, so they may have some nasal changes that may restrict the airflow in the induction period and recovery. You might want to think about supplying more oxygen for those guys. ASA grade is better correlated with underlying health than with age, although older rabbits are more likely to have underlying silent disease, particularly cardiac disease. The radiograph on the right here is a rabbit with a thymoma, and this was a rabbit that actually presented with just generalized weight loss, nothing particularly specific, no real changes in auscultation, no real changes in breathing, and we decided that we were going to just give a tiny bit of buprenorphine sedation for this patient and not anaesthetize at all. And looking at the radiograph, we're very pleased that we did. Think about handling, think about companionship. These are prey species. Prey species don't have many choices in life apart from hide, run or die. And when they're being brought into a veterinary practice and they're being put under stress, the adrenaline levels go up, the heart rate goes up, susceptibility to anaesthetic emergencies increases tremendously. So there are a wide variety of things that we can do with rabbit handling to reduce that stress. The companionship angle of things, it is a sensible idea if that rabbit has a bonded partner. So this is a rabbit that is getting on with well and has been with for some time, to bring both rabbits into the practice together so that when your patient wakes up, it wakes up next to a rabbit that it knows. If you're doing that, make sure you have a foolproof labeling system so that you know the patient that you're actually operating on. And you can see here, these are wild rabbits. You can see how they're depending on the other partner rabbit to protect themselves against predators. One rabbit is sitting in the blind spot of the other rabbit to protect it. Preoperative starvation, not really a big thing in rabbits. Their stomach's never empty. So what I recommend is removing them from food about 20 minutes before you start to give the pre-med. And we also wash the mouth out with clean water to remove food material, and that means that you're not going to be pushing food material down through the pharynx and potentially into the larynx as you place the v-gel. Pre-oxygenation before induction is a very important thing, but there's a couple of things to think about with rapid anaesthesia. This was a human study showing that if a person was taking oxygen for 3 minutes, just spontaneously breathing, it would take them almost 10 minutes to desaturate down to 90% SpO2. So quite a nice safety margin. You got much the same effect if you got that person to spend a minute breathing, but taking deep breaths instead of standard breaths. So deep breathing speeds up the uptake of oxygen, which makes sense. Pre-oxygenation is sensible, but we are dealing with a prey species here. So if you put them in an oxygen tent in a strange environment that may be too hot for them, rabbits don't deal well with heat, it may smell weird, the oxygen coming through may be tainted, so then the rabbits may sit there and be scared. What does a scared prey animal do? It changes its breathing pattern. It breathes in a very shallow way, so it's not attracting the attention of predators. So pre-oxygenation the wrong way in rabbits may not be helpful. This is how I pre-oxygenate my rabbits. So what I've got there's an intravenous cannula. I've administered an intravenous pre-medication, so that patient now has some sedation on board, and I will gently hold a mask onto the nose so that it's sealed, and I will give a number of deep breaths before I then go on to induce that patient. So we're achieving the same effect as if we were putting them in an oxygen tent, but we're doing it in a much lower stress way and in a much more controlled way. Inducing rabbits. So rather than having a recipe, I thought we'd do this. What constitutes a good induction and how do we get there? We're looking for a balanced drug combination that's got elements of sedation or anaesthesia, elements of analgesia, and potentially elements of muscle relaxation. We are treating this patient as a pro-species, so we are reducing stress and fear down as much as we can. Avoid pain. That's really, really, really important with a pro-species. If you can deliver a drug intravenously via an intravenous cannula and it will have the same effect as an intramuscular injection, go with the intravenous delivery. That would be my advice. And most of the anaesthetic drugs can be very adequately administered intravenously. And from my point of view, I find that that's more efficient. I've also then got the patient in front of me, so I'm watching them all the way through. And if there's a problem, I can jump on it straight away. Some form of topical local anaesthetic agent is vital. It's almost impossible to place intravenous cannulae in the lateral ear vein without deadening the skin slightly. So EMLA ointment, EMLA ointment for around about 45 minutes or so before you place the cannula is the best way to do it. Some sort of team communication and checklist, so you've got the culture in the operating theatre sorted out, so that the entire operating team are talking and communicating, and you're bringing the experience of every single person in that room together, and everybody's being listened to, and that gets everyone's heads in the game, so that if you have an emergency in your induction period, everyone is working together to solve it. Short period of pre-oxygenation, and as I said, I'd strongly recommend assisted ventilation when that patient has some sedation on board, and then a calm controlled induction with continuous monitoring. Patient positioning is important. You need to think about that picture that we saw earlier. Think about supporting the chest. Sternal positioning is generally best in the early period of anaesthesia. That's what puts least stress on the chest. Try and avoid troughs which compress the shoulders into the chest. That's making it very, very hard for your patient to breathe. My advice for induction is wherever possible, use an intravenous induction agent. It gives you more control. It means that you can top up dosing. I don't find that inhalation inductions are particularly useful. It's very difficult to achieve a good stable plane of anaesthesia, and they make it quite hard to place either a v-gel or an endotracheal tube. So on the whole, I will be using an intravenous induction agent, and my agent of choice would be alfaxanolone or alfaxan. And then ventilation. Ventilation for me would be across the board. All of my patients in the induction period are going to be ventilated, and it does a number of different things. It tells me that my airway device is in the right place. It tells me that the lungs are functioning fine. It gives me CO2 readings. It gives me pulse oximetry readings that are in the range that I want them to be. So my rule of thumb is, if it's a rabbit, you ventilate, and then you adjust the ventilation to things like CO2 readings. Bad induction for me, anaesthesia recipe. It's a rabbit, it gets this. You're going to miss a great deal there. You're going to end up giving patients unnecessary drugs, or you're going to end up not giving patients drugs that they actually need. And particularly that things that people tend to forget will be adequate analgesia for the procedure that you're undertaking. Going straight into induction with no team discussion, a quick round the table discussion and filling in of a checklist gets everybody's heads together. So going into the room, putting the rabbit on the table, inducing it straight away. If something goes wrong, people aren't thinking together at that point. Unnecessarily painful routes. If you have a painful way of administering a drug and a non-painful way of administering the drug, just use the non-painful way. It's easier and it's quicker and it's less unpleasant for the patient. And then this face mask induction or inhalation induction, I don't like it. It's massively increasing fear and stress. It doesn't give you a good depth. It doesn't give you a good stability of anaesthetic. And the most important thing from a health and safety point of view is that you're contaminating your working environment with a potentially dangerous volatile agent. And realistically, intravenous inductions are simple, they're easy. It's what we're all doing for dog and cat anaesthesia anyway. And once you've switched over from inhalation induction to intravenous induction, I think it's very unlikely that you'd go back again. One thing that I also find with inhalation inductions, every single time I've seen people doing that, I've heard laryngeal spasms either during intubation or v-geland placements. And that's because of the insufficient anaesthetic depth that you get through these inhalation inductions. Okay, when we're using v-geland, then how do we go about doing it? There's a workflow that's quite useful. So you've worked through your preparation period, you've got a patient in your theatre. Lavage the mouth, remove any debris. Induce and oxygenate that patient as we've been talking about. Check the mouth and remove any debris. And you can either use a laryngoscope, they're quite handy. Some people will use a mouth gag and cheek dilators to see into the mouth properly. And a soaked cotton swab or cotton bud is very useful for removing any hay fragments or any food fragments that might be in the mouth. Look at the sizing guide for the v-gels and choose the most appropriate size for that animal. It will take you about 2 or 3 weeks of regular use before you will start looking at the rabbit and saying, okay, that one's going to be a size 2, that one's going to be a size 3. Until you get to that point, just use the sizing guide, that's what it's there for. You apply an appropriate dose of topical lidocaine to the larynx, that gives you some laryngeal protection, and you then wait for a period of time to let any laryngeal spasm resolve. Insert the v-gel into the pharynx, and normally what I do is I'll insert it in. You'll feel a little bit of resistance as you get to the pharyngeal arch at the back of the mouth. It will then glide into the pharynx and drop very, very slightly. I'll normally give it a slight wiggle and a slight reposition to check that it's seated in position, and then I connect it up to my anaesthetic circuit. At that point, I'll either flick my ventilator on or I'll squeeze my rebreathing bag. Generally, with most of our pet rabbits, you want the smallest rebreathing bag that's available, 250 ml rebreathing bag, nothing more than that. These animals have a tidal volume that's around about 6 to 8 mils per kilo, so taking a 1 litre bag and squeezing it hard is a recipe for disaster. So smallest bag that you have available and just squeeze gently. With the ventilator, I normally use a Vetronic ventilator, the SOV04. I'll set that up to begin with for a relatively frequent ventilation cycle. So I'd start at a seal pressure of around about 10 or 11 centimeters of water and a breath around about every 4 or 5 seconds. And that's so that I get a breath straight away and I can check that the chest is lifting and I'm getting no leakage and I don't need to reposition my v-gel. Once I've got that sorted, then I will normally drop that back to breaths around about every 7 to 10 seconds, and then I'll look at my capnograph to adjust the ventilation speed and depth. If you're ventilating with a rebreathing bag, you will still need to ventilate for rapid anaesthetics because they don't breathe that well, and you just alter the amount of squeeze and the frequency of squeeze to keep your CO2 readings within acceptable limits. You then secure the v-gel using a tie around either the little tying points on the connector or around the neck of the v-gel itself, and that goes around the base of the head behind the ears. And the D-grip that Dr Ivan make, that's extremely useful for rapid anaesthesia. That will support your circuit tubing and stop your circuit tubing displacing the v-gel or potentially even pulling it slightly out of the mouth. I also find it's very useful for my monitoring cables. I'll wrap those around the little rubber supports of the D-grip, and that stops my monitoring cables lying around all over the table. Respiratory monitoring is absolutely fundamental for rabbits. So rabbits don't ventilate effectively under anaesthesia, and because they're not excreting the CO2 properly from the lungs, CO2 levels are going to build up and they get toxic remarkably quickly. You need to be monitoring that CO2 level regardless of what airway management method you are using. And in order to improve lung function, you need to ventilate the lungs either by squeezing the rebreathing bag, as we were talking about just now, or by using an anaesthetic ventilator. And you alter the rate and depth of ventilation according to your CO2 or according to blood gas analysis. And here we can see a rabbit under anaesthesia. You can see on both pictures that little blue bandage that's covering an intravenous ear cannula. You can see the v-geland advanced in place, pulse oximetry probe in there. That's a pediatric CO2 capnograph connector. Pediatric connector has a reduced dead space going through the middle, so we're not making it harder for a patient to breathe. And then you can just see behind the ears a little bit of our tie that's securing and holding that v-gel in place. Moving across to the right hand side there, in the background on the left you can see my anaesthetic ventilator, tubing coming through being supported by the D-grip, and then CO2 and pulse oximetry. CO2 or capnography and pulse oximetry will be my minimum standard of electronic monitoring with rapid anaesthesia. The other things to think about when you're anaesthetising a rabbit is the basics. Full and undivided attention from an anaesthetist who's concentrating on that anaesthesia. You then combine the manual skills of the anaesthetist with electronic monitoring. The aim of the game is to react early. So when you see a change, you deal with it, you monitor it, you manage it, so that change doesn't turn into an emergency. And hypercapnia, I would suggest, is a normal finding in rapid anaesthesia. It's not something you should ignore, it's something that you should do something about, ventilate and manage it. But pretty much every pet rabbit that you're going to be anaesthetising is going to be hypercapnic at some stage of that anaesthesia, if not all of that anaesthesia, and you should be looking out from that from the first minute of your anaesthetic procedure, monitoring it and ventilating that patient. When you are monitoring your patient, when you're looking at chest movement, rabbits breathe with the diaphragmatic muscles rather than the intercostal muscles, so you need to be looking at the caudal aspect of the thorax where the diaphragm is for movement. You need to monitor the thoracic movement or the diaphragmatic movement together with the movement of the rebreathing bag. So movement of the chest does not mean that you have a clear airway. It just means that you're moving your chest. If the rebreathing bag is moving at the same time as the thorax is moving, you're good, then you have a clear airway. And ventilation has got multiple points to it. It's both assisting your patient and dropping the CO2 level down, but it's also checking your airway every time you ventilate. So it's a very useful technique. Capnography, as we were saying, is fundamental. Whether you're intubating your patient or placing a v-gel, it's giving you real-time measurement. And notice that I'm saying capnography, not capnometry. Capnometry just gives you a number. Capnography gives you a real-time trace of what that CO2 is doing. And with some experience with capnography, you can get a lot of information out of the shape of that trace. It's very, very useful indeed. Arterial blood gas analysis is a little more accurate than a capnograph, but it takes longer, it's more expensive equipment, so that's for the more specialist anaesthetists, but it does have value in rabbits. Here is a video of a capnograph. I shall play this in a second. Now, what this is showing us, this patient was on my SAV ventilator. The capnograph, here, let's play that. So you can see the capnograph trace going up and down. The baseline of the capnograph if you look on the left-hand side of that trace now, the very furthest trace to the left is going down to the baseline. The other traces all the way across are not going down to baseline. They're staying halfway up. Now, this patient was breathing quite noticeably. It had good thoracic movement, and we were giving it an assistance breath around about once every 10 to 15 seconds, I believe. CO2 is only going down to baseline when we give this patient an assisted breath. And what this means is the patient, when it was breathing for itself, was not clearing all of the CO2 out of its airway before it breathed back in again. And that patient was rebreathing. When we ventilate for that patient and help it, then it's clearing all the CO2 out of its system. So what we were doing here is, rather than taking over the breathing completely for the patient, we were just helping it along with a breath every now and then, and that was keeping the CO2 at an appropriate level. What you're looking for there in millimeters of mercury is a number between around about 35 and 45. And what we were finding was that frequency of ventilation was absolutely fine. If the numbers had kept on climbing from there, then we would have increased the frequency of ventilation and brought those numbers back down again. With dead space, large dead space volumes are going to do a number of different things. They're going to make it more difficult for your patient to breathe, and that's what we could see in that video there. And sometimes any extra dead space, anything that you put into that rabbit, can cause problems. It's not a big deal if you see that, you just have to ventilate and manage it. If you have a large volume dead space at the front end of the system, that means that incoming oxygen is going to dilute your CO2. So the CO2 reading that the machine is giving you is going to be less than the actual CO2 that the patient is breathing out. Another thing to consider when you're using electronic monitoring with rabbits is taking temperature. Now, taking temperature is very important with a small animal like a rabbit, but remember that they have a very, very, very fragile rectal mucosa, and it's not uncommon for people to perforate the rectal mucosa when taking rectal temperatures. So make sure that any temperature probes that you're using or thermometers that you're using are well lubricated and gently handled. I also find blood pressure monitoring, pulse oximetry and ECG monitoring are useful, and probably in that order. So for me, as always, the most important thing is an anaesthetist who is paying absolutely full undivided attention to that anaesthetic, together with a capnograph. The two things, I think, are not divisible. You need the anaesthetist and you need the capnograph. From there, I will then go for temperature monitoring, blood pressure monitoring, pulse oximetry and ECG in that order. When you are recovering these patients, there's a few things to consider when you're using v-gel advanced. The v-gel advanced does not rest on the larynx, which is great, particularly from the patient's point of view. But from your point of view, do not expect a cough reflex. When that patient comes round, the shape of the v-gel advanced is such that the epiglottis just rests naturally in the middle of the space in the centre of the v-gel, and it's not being touched at all. And it's very rare for v-gel advanced patients to cough in recovery. I normally look in rabbits for very small amounts of head movement, little twitches, things like ear twitches and things like that. And you'll see the eyes just start to swivel and move a little bit, and the rabbit starts to look at you. And at that point that you see that eye movement, they're going to sit up very, very quickly. Now, of course, that's the point that I'd be panicking a little bit if I had an endotracheal tube down, because you're trying to stop the tube amputation. The v-gel advanced is much tougher than the endotracheal tube, and of course it's too large to be inhaled. So it's less stressful in that recovery period. But to avoid panic, you do not want to be leaving a v-gel in the mouth of a conscious or semi-conscious patient, because they're not going to like it. So at the point that you start to see conscious response, remove the v-gel. Sometimes if the v-gel is very firmly placed in there, you need to rotate it slightly clockwise or anti-clockwise to unlock that seal from the pharynx and then remove it. The advantages that you've got with the v-gel advanced, well, it's as we were discussing before. Intubation is bypassing the larynx, the epiglottis is being pushed ventrally onto the floor of the pharynx, and in recovery your larynx and epiglottis needs to return to a normal function, which takes a little bit of time. V-gel advanced is letting those arytenoid cartilages work as they normally would. The epiglottis is functioning as normal, directing air like a gutter down into the trachea. So when you remove the v-gel advanced, the larynx has got very little work to do to return to a normal function. And what we see is a very nice rapid return to normal breathing. We certainly are not seeing the kind of coughs that we'd see from endotracheal tubes. And what I see when I use them in practice is a very rapid return back to eating. And I think that that's because the v-gel advanced are very, very gentle on the upper airway, and we're not getting the pain that you would get from an intubation. The technical advantages of the v-gel advanced, what I see when I use these in practice, very much easier to use for ventilation even than the original v-gels, and certainly much easier to use for ventilation than an uncuffed endotracheal tube, which is what I was using before. You've got that increased ability to do dental examinations and dental procedures. You've got that nice, fast, easy to place system going on, so that you've got a very rapid induction period and you can get these animals ventilated very, very quickly indeed, sometimes in a matter of seconds. You've got that increased stability over the original v-gel, and I certainly find that they're much easier to use in practice. And then no narrowing of the airway, so you're just keeping a natural airway diameter all the way through the airway system. That low dead space connector certainly helps. It's just a small improvement on the original v-gel to make it safer to use. And that single-use design, well, it's got clinical advantages, and certainly rabbit viral hemorrhagic disease is a very significant risk at the moment. And I do like to use devices for single use only in rabbits for that reason. It also makes it cheaper to hold a larger range of devices in stock. And then from a personal point of view, what do I see about it? And I do a range of rabbit procedures, from first opinion spaying and castrating rabbits, first opinion dentistry, right up to second opinion complex dental procedures and abdominal procedures. I think for me it's two things. It's the speed, it's the ability to have my rabbit on the table, go through that intravenous administration of drugs. I've got my rabbit going under anaesthesia in a nice controlled manner, and then I can very quickly place a v-gel, connect up my ventilator, flick the switch, start ventilating, get CO2 readouts very, very quickly indeed. So I'm not sitting there wondering and worrying about that patient. And then it's that outstanding quality of recovery, and particularly with the new induction agents with superior analgesic options that we've got available to us now, to be able to look at that patient waking up from anaesthesia, see it sit up, stand up, start to move around, and then go back in with its partner rabbit and start eating. That's quite special, that's quite important to me, and that's one of the big reasons that I use the v-gel devices over endotracheal tubes. I see a big difference there. So that's it for our run through of how I fit the v-gel devices into our anaesthesia processes in my clinic. If you've got any questions or you want any more detail, come to www.docsinevent.com. There's more information up there, and if you have any questions that haven't been answered with this presentation or with other videos that are on the site, please get in contact with us through the site and we will do anything that we can to answer your questions. Thank you very much.